dive into the heart of our content for today, which is focused on colorectal cancer screening and treatment. And then we'll have time at the end for some questions and answers from our physician panel. We'll meet the panelists first. Dr. Brano Djenic is a board-certified surgeon and a member of the practice. And by way of introduction, Dr. Djenic, can you just give us a sense of how you came to be focused on this particular area of oncology care?
Thank you, Ed. I will just briefly tell you it was a multifactorial decision. When I was a child, I had gastrointestinal issues that were corrected by multiple surgeries. And throughout college, my uncle was diagnosed with colon cancer at age 46. And then shortly after that, a close family friend, even at an earlier age, and they both were cured with surgery and are still alive many years later. And throughout my surgical training, I had some excellent mentors in colorectal surgery and was exposed to many new devices and toys that were both challenging and fascinating. So for me, it's a decision that was, based on great patient outcomes, new technology, but also it was personally very gratifying.
All right, Dr. Djenic, thank you very much for that explanation. Our next physician is Dr. Michael Kardys. Dr. Kardys, same question. What led you to specialize in this particular facet of oncology care?
Two things really come to mind. One is that when people have a pain in their backside and you're able to take care of it, they tend to be so grateful they jump up and hug your neck. Also is that we have excellent success in both diagnosing and preventing colon cancers, as well as success in treating colon cancers. And so the ability to cure a cancer is a very rewarding thing.
All right, thank you, Dr. Kardys. Dr. Michael Keller is also on the panel today. And Dr. Keller, tell us a little bit about your background and how you came to specialize in this particular area of oncology care.
During my training, I quickly became fascinated with the concept of minimally invasive surgery and doing these really complex abdominal operations through only a few incisions. When added up, were only a few inches. And so that naturally led into laparoscopy and now robotics. And the field of colorectal surgery definitely took advantage of that and was appealing, and then quickly found that I enjoyed the pathology that we treat. And as Dr. Kardys had mentioned, very grateful patients, and it was a very natural decision.
All right, Dr. Keller, more on those new treatment methods in the heart of the discussion we'll have today. But for a moment, let's talk just a little bit about Texas Oncology. We are a large physician-owned oncology practice. We have nearly 500 physicians now. We have practicing at 200 locations across the state of Texas. We are a pioneer in community-based cancer care, and we have a focus on evidence-based care as well as value-based care models. The breadth and scope of medical services at Texas Oncology is vast, as you can see from this list of the services that we do provide across the practice, including proton therapy at a modern and innovative center that's located in Irving outside Dallas. With regard to our practice in San Antonio, we have 44 physicians who are treating patients at 15 treatment locations. This includes 4 comprehensive cancer centers, and for us, when we say comprehensive, we mean that we offer radiation oncology, medical oncology, and other special programs and services in those locations in particular. And we also have more than 60 clinical trials currently open in our San Antonio practice. And we'll move now to the subject matter at hand for today's webinar, and that's beginning with a discussion of colorectal cancer screening. And that's from Dr. Djenic. Will get us kicked off.
These are just some basic numbers that highlight the importance and prevalence of cancers in the state of Texas. New cancer cases in Texas are nearly 130,000, and of those, over 11,000 are colorectal cancers. And over 40,000 of Texans will die of cancer in 2020, and about 10% of those patients are colorectal cancer patients. And proportional to the size of the state, Texas is the second in the country in both new cases of colorectal cancer, but also of expected colorectal cancer deaths for the 2020. A few other facts about colorectal cancer. This is a cancer of the lining of either colon or the rectum, and it is the second leading cancer killer of men and women in the U.S. Approximately a third, or unfortunately, about 1/3 of adult patients over age 50 have never been screened for colon cancer. And successful colorectal cancer treatment heavily depends on early detection and quality of care. Preventing is obviously a vital step, and for those cancers that are found in their early stages, before metastasis, before spread, the survival rates are excellent and can be 90% or higher for 5-year survival. One of our newer guideline changes in the last 2 years or so is that colorectal cancer is now recommended to be screened for starting at age 45, and this is for both men and women. And we do have a multitude of tests which can be used as screening modalities, but colonoscopy is considered the gold standard exam. It is the only test that is both therapeutic and diagnostic. And if a colonoscopy is negative for cancer, that is the only study which allows for 10-year between the next screening. There are other options, tests which include both blood samples, stool samples, partial colonoscopies, and imaging studies called double contrast barium or virtual colonoscopy. One thing I do want to point out is all the above tests, or all the tests mentioned on this slide that are listed above colonoscopy, are not as sensitive nor as specific as the colonoscopy itself. And our recommendation is for any patient who can undergo colonoscopy is to undergo a colonoscopy. And if there are some specific contraindications, then one of the other tests can be used instead. And lastly, all of the tests listed above the colonoscopy, if they are positive, the next step in diagnosis would be to get a colonoscopy.
As Dr. Djenic mentioned, colonoscopy is the gold standard, both because of its sensitivity and its specificity. Also, it is one of the rare tests in medicine that has the potential to prevent the very disease that it is looking to detect. As we all know, there are benign polyps of certain varieties, adenomas that can develop into cancers. And if we can nip those in the bud or remove them prior to them developing into a cancer, we may very well even prevent a colon cancer. Screening and the vigilance with focusing on screening is very important. All of us will have plenty of stories about how someone comes in and they've done a reasonably good job when the recommended age was 50. They come in at age 52, didn't wait terribly long, but you wish they'd come in at 50 because there's a cancer at age 50 that was probably still just a polyp. I'm sorry, there's a cancer at age, say, 52 or 53 that was probably just a benign polyp a few years earlier. I think talking to most colorectal surgeons and as well as gastroenterologists, we would like to be able to do more of these more frequently, but at a minimum, we need to stick strictly to the guidelines. Unfortunately, we have recently seen in the statistics and medical data something that a lot of surgeons and gastroenterologists had been perceiving, and that was that we were seeing younger and younger patients presenting with colon and rectal cancer. And that was borne out in the recommendation of decreasing the recommended age of screening to 45 from age 50 for the entire population. Some of those disturbing statistics include that people born around 1990, so 30-year-olds, are now twice as likely over their lifetime to have colon cancer compared to someone at age 50, thus making the screening much more important. And because many people, including medical professionals, are not aware of this, many younger people will have their disease be more advanced as symptoms are attributed to something else. People think, oh, that could never happen to someone my age, and they don't wind up getting checked when they present with symptoms. So the list of symptoms we see here on the slide really can be summed up in bleeding, weight loss, abdominal pain or distension, or a significant change in just a significant change in one's bowel function. All of those would warrant a colonoscopy for evaluation. Also, anemia is on that list. Anyone who has iron deficiency anemia should receive a colonoscopy as well as an EGD to look for a potential source for that bleeding. Unfortunately, though, most people are more advanced with their disease when they do see symptoms.
All right, so let's go over a few more facts. We'll try this as some true or false questions. So number one, women are diagnosed with colorectal cancer more often than men. That's not necessarily true. The risk is equivalent between men and women, and so we really don't make any discrepancy in terms of recommendations. Everyone is recommended to undergo their scopes at the same age, assuming the same risk factors. Next, my risk for colorectal cancer increases after age 65. That is actually false. Your lifetime risk for colon cancer remains the same, right around 6% for someone with normal risk factors. Now, the classical teaching has been that the incidence of colon cancer does go up after 65, but as you've already realized, that trend is being bucked, and we're now seeing people at lower age. But waiting until 65 is not a good reason because your risk is the same regardless. Next question, my family history can place me at higher risk for colorectal cancer. Absolutely. Anyone who has a family history of colon cancer is at higher risk and needs to get screened at a sooner age based on the age of the primary family member. So definitely has a significant impact on screening requirements. Diet and weight are important risk factors for colorectal cancer. Absolutely, that's very true. We often have found that obesity, dietary habits, that is, low fiber, high fatty foods, likely has an association with colon cancer, and in addition, comorbidities that go along with poor diets and weight issues can make treatment for colorectal cancer much more difficult. And in the same respect, my health history has little bearing on my colorectal cancer risk. Well, that's obviously false. As we mentioned, comorbidities, weight gain, obesity, all that can have an effect on both treating and the outcomes for treatment of colorectal cancer. So with that in mind, what should we encourage our patients to do? Well, maintain a regular exercise schedule and a healthy diet. Those things will improve your overall health. And should you have a diagnosis of a colon cancer, you're in a better position for us to treat it. That includes eating a diet that includes fruits, vegetables, and whole grains. In other words, a high fiber diet. We strongly recommend a high fiber diet of around 25 to 30 grams a day. And it's also important to couple that with adequate water intake as well on a daily basis. limit your consumption of red and processed meats, limit your consumption of alcohol. Again, that all goes towards high fiber diets, minimizing red meats, being careful with your diet intake. And then you can discuss the use of aspirin, NSAIDs with your patients, because there is some evidence that has demonstrated that use of NSAIDs can reduce the incidence of polyps and thus possibly reduce the incidence of colon cancer. That's still being worked on. And of course, that should be managed with the current discussion as well about the risks of the NSAIDs at the same time with regard to bleeding, ulcers, and so on. So if you do have a colon cancer diagnosis, treatment is often multimodal. One of the hallmarks, obviously, that we concentrate on is the surgical treatment, and that will usually involve the colectomy with or without a colostomy, or at least placement of a colostomy if it needs to be done as a palliative measure. We can do those usually as a minimally invasive approach in most cases now, which means robotics, laparoscopy, or in some cases, a single incision approach. But again, I mentioned this is multimodal, so patients often will also require potentially chemotherapy, radiation therapy, some type of ablative procedures, and there's a lot of advances in immunotherapy and targeted therapies. Again, one of the things that we pride ourselves at Texas Oncology to be able to offer the full multimodal treatment for our patients when they come to see us. And always be aware that there may be clinical trials available too for different variations, different treatments, advanced treatments, options for colorectal cancer. So COVID-19 obviously has dominated our lives now for the better part of this year. And unfortunately, one of the byproducts of that is that a large number of people are skipping their screening procedures, of which colon cancer is a big one, out of fear of contracting COVID or just not knowing what to expect from their treatment. We highly encourage patients, do not skip your screening. It's important to do so. The risk of missing a critical diagnosis is just too high, and it's just essential to proceed with screening as scheduled. And we have gone through great lengths to put in safeguards to make sure that the safety to both the patients and the staff are there in place to really make it safe to come to the office. You know, if you do have symptoms and you're concerned, obviously call the doctor, see if your symptoms validate a workup before coming in. But otherwise, if you're feeling well, we've implemented strict safety precautions. All of our treatment areas, whether it's chemotherapy, radiation, or surgical based, have safeguards in place, screening processes to keep everyone safe. And there are alternatives. We can do telemedicine consultations with regard to follow-ups or visits or even acute care visits. It's been long enough now, we understand properly how to set up the clinic to keep it safe for our patients.
All right, Dr. Keller, thank you especially for the review of the safety concerns and safety precautions that are in place, because we know that across really all types of cancer, that is an important issue in light of the pandemic. We'll transition now to the Q&A portion of today's webinar. We have several questions that have been submitted in advance by some of our participants. We'll move through several of those questions in the time that we have left. The first question is for Dr. Djenic, and the question is, if a patient has a negative colonoscopy, what are your thoughts on doing a fecal immunochemical test, a FIT test, in between colonoscopies?
That's a great question. I have personally thought about that myself. Whenever we screen somebody who has no polyps and we recommend a 10-year follow-up, you always wonder if a small 1 millimeter polyp that was missed may turn into cancer before the next colonoscopy. However, based on the data that we have so far, it is not recommended to have any supplemental tests between the colonoscopies at this time.
All right, Dr. Djenic, thank you so much for that response. This is a related question for Dr. Kardys. Do you have any tips for patients or for helping patients get colonoscopies covered by insurance? And for example, when in the event of someone who has a FIT test, and then the FIT test indicates that then the follow-up colonoscopy is needed, what are your recommendations or advice would you have for patients to be able to get the colonoscopy covered by insurance?
Well, one of the advantages of using colonoscopy as a primary screening tool is it is generally covered by most insurances pretty generously for screening on a routine schedule. When we get into a diagnostic or a follow-up colonoscopy, that is more often paid or has to be paid for out of someone's deductible as any other procedure. That's one reason that if someone is a suitable candidate for a colonoscopy, our best bet is probably just to go ahead and get the colonoscopy and have that count as the screening test. Now, if they need a repeat test at some point along the line, it can be something that people try and strategize a little bit for. I personally had just planned out that I would pay for my first screening when I turned 40. It turned out that I had 2 knee surgeries when I was 39, and I had spent up my deductible, and so I just went ahead and paid for one, and it was pretty well covered at that point. And so those are some of the tricks that we can kind of keep in mind to help make sure we're able to get one and that it's a little bit more affordable.
All right. We appreciate that, Dr. Kardys. Of course, everybody's individual insurance circumstances and requirements may vary, and so it's just something that individuals do need to pay close attention to as they think ahead to this kind of cancer screening. We have a question from one of our participants on the webinar today. So, Dr. Keller, I'm going to shift gears on you and send this question your way. The question is, please speak to the utility of the DNA screening tests.
Yeah, so the DNA screening tests have really come onto the scene over the last few years. I would say that they really have been a great alternative for patients who are not going to get colonoscopy. They come in and they just aren't going to do it. Well, then it's a great alternative to say, well, here's something you can do. And then if that's positive, they're able to then get the colonoscopy. Now, it is important that it's not a catch-all. There's a known missed rate. There's about a missed polyp rate, I think, in the mid-teens. And there is a known missed colon cancer rate. I think the most recent studies show somewhere between 3 to 6%. So as long as they're aware that it's not a perfect test, it's a good option if they're not going to get a colonoscopy. However, if they are willing to do it, I would still strongly encourage them, get the better tests, and that's always going to be a colonoscopy.
Right. As a couple of you have mentioned, the gold standard when it comes to this is the colonoscopy, and we don't want to lose sight of that, even as the other testing options advance and become available and helpful in certain circumstances. We have another question for Dr. Djenic. Why do you think the occurrence in younger people is happening with regard to colon cancer?
So most likely it has to do something with our environment. Most likely it's related to the increased prevalence of obesity in younger folks, as well as overuse of processed foods, and really the low fiber, high fat diet that we are used to. Most of the colon cancers, even in younger patients, are not related to genetic predispositions. In fact, over 90% of colon cancers are still considered sporadic. For us, it still goes back to the dietary insults that start off when you're a child, and 30, 40 years later, that is enough to start carcinogenesis and ultimately end up in cancer or end up with cancer.
All right, Dr. Djenic, thank you. This question is for Dr. Kardys. How, and it's related to the discussion above about young people, what could you suggest as ways to get younger people to take greater notice of this increasing risk? It is a new and unexpected concern in the lives of young people. What should be done to help them, pay more attention to this? Again, this is for Dr. Kardys.
Well, certainly when someone who's famous catches any disease, it raises awareness. When I was growing up, I remember both Katie Couric's husband getting colon cancer and getting a colonoscopy on the Today Show. And I remember a baseball player named Eric Davis getting colon cancer, and that kind of raising some awareness. But I think it may have fallen off of people's radars recently, but until recently, when Chadwick Boseman, who's the young actor who played Black Panther in the Marvel movies, recently died of colon cancer, and he was diagnosed in his late 30s. I believe he was 39 and died at 43. That happens to be my same age, and so it certainly helps me to take notice. And you certainly wish that there would have been some means that he would have been able to get evaluated sooner. And so hopefully that is something that just raises awareness that if people are having these symptoms, both as they're reporting them to their physicians and that the physicians are responding to them, that colon cancer could be one of those things that is causing their symptoms, and they would benefit from a further workup.
All right, Dr. Kardys, I think we have time for one more question. This is for Dr. Keller. What treatment advancements or research projects regarding colon cancer are you most optimistic about? What do you think are the kinds of treatment changes that are most likely to occur soonest and that hold the most promise?
Well, there's two fronts I think that we're excited about. One is more on the preventive front in terms of actually figuring out trying to predict who's more likely going to get these. And of course, that goes through genetics. There's also been discussions about patient biomes and their makeup and how that might lead to a higher risk of colon cancer and prevention. In terms of therapeutics, immunotherapy, genetic targeted therapies are gaining a lot of traction. And then obviously I'm a surgeon. And so our reliance on less invasive approaches to cancer gets better and better. Again, the concept of being able to do a big complex colectomy or low anterior resection for rectal cancer, and the patient literally within hours of the operation is walking and leaving the hospital within a day or two. I think that's fascinating. And when we have those and can provide those outcomes for patients, it's less intimidating. They're more likely to seek treatment, seek a diagnosis, and have better outcomes for everyone in the long run.
All right, Dr. Keller, thank you for that answer. And I'll again thank all of our physician panelists today for participating in today's webinar on colon cancer risks and treatment options. And we want to thank all of our participants who joined us on today's webinar. If you'd like more information about any of the topics that were discussed today, there's a wealth of information on the Texas Oncology website at www.texasoncology.com. The webinar has been recorded, so we'll be making that available in some manner. Thank you all for your time today, and again, for joining us today on today's webinar.
Thank you, Ed, and thank you to all the participants.
Thank you very much.